Thank you. I'm actually live. Sorry to change anything that you're expecting, but I'm live. And one more apology before I start the presentation, which is I need to jump off immediately after my presentation. I have a family issue, but Fliss knows everything that I've been doing, so she'll pick up anything I know. Thank you so much for the chance to join you and to be part of this very interesting collaboration. And I've got just a few minutes to talk about how we're using outcome metrics and data to inform policy at St Christopher's and how we would like to do more. So I thought I'd start by talking about why I believe outcomes should be important to policymakers. I'm keen to talk about what we're doing at St Christopher's, and I'm going to talk about the good, the bad, and the ugly, and our efforts to shape local and national policy. And then I'm going to make some suggestions at the end about how others could further enhance our efforts and how we might work together. So the first question is, why bother with outcomes? And I think it's time. In the UK, we have a phrase which is it's time to talk turkey, which means to talk the real truth and to say it without ambiguity. And for me, I think that our policymakers in the UK have a skewed attention to experience and give too little attention to effectiveness. Our regulators are increasingly focused on safety, and hospice and palliative care services would love to aspire to be good at all three elements of quality, but they're very expensive in the UK, and the degree to which we are value for money, I think, can be questionable and is certainly questionable to policymakers who are looking at increasingly using increasingly finite resources to meet growing need. And finally, I think there is a question for us with our integrity as providers in a health, a social care system, even a death system, about to what degree we do make any difference and where are we best located to do that. And I know that I'm speaking from a provider perspective, but those shaping and implementing policy do want to know more. And I think there are a number of questions that policymakers are asking themselves, and we can help them with outcome measures. So the first is, what value does hospice and specialist palliative care make in a health economy that is increasingly stretched in terms of resource and must find new ways to meet growing demand? And the second question is, okay, we'll fund hospice and specialist palliative care services. We know they're a good thing, but how should they be positioned in relation to other services? And we have an old argument, which is around generalist and specialist. That feels very antiquated to me. But if we are expensive, if we are a finite resource in our own, as we are as specialists, then where should we be positioned and how are we best located so that we represent value for money in that bigger system? And then finally, I know at St Christopher's, there are things that we could do better. We need investment into improve on. And I think policymakers, local, particularly our care commissioning groups, our commissioners, they might be interested in investing further in us, but they would want to invest in the areas where we could be most impactful or where we're least impactful now, but potentially could have greatest value in terms of the system-wide approach to end of life moving forward. We in the UK have a new system which is literally just about to come into being. It's an integrated care system. We've seen it in other guises historically, but it is decentralised, but for very large populations. And at a conference that Fliss and I were recently at, Jonathan Ellis, who is the head of policy for Hospice UK, said, I think, very well, that our big challenge and he was talking to hospices in the UK, is to pull through national aspirations around outcomes into local conversations with integrated systems. And I want to add to that conversation and say, yes, but vice versa too. We as providers need to, and as ICSs, need to take local insights and then translate into regional and national policy to shape priorities and investment. So I see the conversation about outcomes and policy as two-way, up and down. We've seen huge changes in the UK and at St Christopher's in the context that we're working. I won't need to tell you about the stress that health and social care systems are under, but perhaps more interesting, these new groups of people who could benefit from palliative care are emerging. Some of them are anticipated, they've been anticipated for 10 years plus, that aging population, people living with frailty, comorbidities for many, many years. But we've also seen some interesting groups emerge post-pandemic, people in care homes with significant rehabilitation needs, by way of example, who've become really decommissioned as a result of extended isolation. My colleagues at St Christopher's describe increased complexity on the part of the patients that they look after as the new norm. And I've every reason, by looking at the data, to believe that's the case. As I said, people are presenting with increased and different manifestations of need post-pandemic, particularly around the psychological and the social. And I'm seeing emerging organisations in the system with different roles in end-of-life care. And I'm thinking particularly of care homes and their residents. We have always at St Christopher's supported care homes, but we would not have noticed residents with the kind of complexity of need that we're noticing now in the residents that are being referred to us for highly specialised advanced symptom management, for example. So moving on to what we've been doing at St Christopher's, we've been working with FLIS and others at York Hull for a while to collect outcome data. We've been doing it for nearly 7 years, and it spans home and inpatient care and care residents too. I would be dishonest if I told you that all our data was are high quality. We often get first measurements. We don't always get second measurements. And I think that we are only now starting to be really true to these measures being patient reported rather than staff reported as a proxy. And I don't know historically how consistent we've been in the use of phase of illness, for example, but we're getting much better at it. And if you're interested, interested, and you haven't embarked on this journey yet, it's a long one, but I can't tell you how worthwhile it is. And our conversations with other hospices, with our commissioners locally, with government, is enhanced as a result of measuring outcomes. We use seminal work that was led by the OAK programme. These are the measures that we use, and we are constantly increasing them and trying to become better at using them and using them consistently. And we have our own version now. We use the measures, they're validated, very, very helpful. But we have created ways in which we relate to the patients and others in our care in order to get the conversation about outcomes going. Okay, I'm going to suggest 5 reasons why using outcome measures can be really helpful in shaping policy. And the first is that I think it confirms the role that we all have in providing the much needed holistic care for patients and their families at the end of life. And I don't believe that this ambition is a frothy one. I see in the NHS in the UK an increasingly reductionist approach to what good looks like, and that often doesn't take on board the holistic requirements of people. It's very utilitarian, it's niche, it's about being in a production line very often, and that puts at jeopardy everything that you and I know is important for people who are dying or face grief. I think it expands the KPIs that commissioners and others want to give organisations like St Christopher's to represent quality. It's importantly, we've done a lot of work at St Christopher's with our patients and families about what they think is important. And holism is everything for them. They want to feel a person. They want to know that the needs and the wants that we're going to attend to are greater than their very narrow physical requirements. And it allows us to protect what we think is most important moving forward. So as I say, this is how we do it. We ask people to complete a form either on admission or on referral to the hospice, and then we follow it up so that we have at least 2 or more measurements to measure the impact that we have over a period of time. And I wanted to show you positively the picture of holism that we see at St Christopher's Holistic Care. So this is inpatient data over 2 years, and you'll see we've got 1,200 patients data here. And this is perhaps what you might expect to see. These are the physical symptoms in a patient. You see the red line is the episode start, the green line is the episode end. And the fact that there's a reduction in that shape shows us that we're having a positive impact on symptom burden. But we don't just measure physical symptoms. And this is the same picture for psychological and social impact of advancing illness. And I'm pleased to say that you see the same pattern for that as well. We see a similar pattern for our community patients, not so great, but you would expect that. Our community patients might see somebody from the hospice once a week. They might get a call twice a week, but there wouldn't be anything like the intensity of the care that they get on the inpatient wards. But this is for over 5,000 patients, and that's great news to see those numbers. The next reason that we might want to collect outcomes is because we want to show that we add value in the system. And there are mixed views as to whether St Christopher's is worth its cost to the health and social care system. I think when we talk in terms of experience or emotional value, when patients say to us, it feels so good being here, that's all very nice, but it probably isn't worth the cost of us. And our local commissioning groups vary hugely in the degree to which they want to invest in hospice services and the innovation that we can provide. And if we can't show we add value, how on earth do we argue with that? So this is data that is a bit earlier than the last data I showed you. It's from 2019, but it shows you the proportion of patients with moderate, severe or overwhelming symptoms that improve with our care. And the picture is really affirming that we have a value in a system for a population where there are about 10,000 people that die a year. And the second, this slide, I think, is just as important. It's often ignored by our commissioners. It's often misunderstood by our policymakers. But actually, a lot of the work we're doing is avoiding those symptoms happening in the first place. And so this shows the proportion of absent and mild symptoms that don't worsen in the course of the care that people get from St Christopher's. So we're keeping people well. And of course, that's at the heart of the philosophy of palliative care. The third reason is that it allows us to protect resources where we think they add particular value. And our inpatient unit, it's very small at St Christopher's now. We have under 30 beds. We have 1,200 people at home at any one time. So it really is the tip of the iceberg, but it's a very expensive element of our service, and an important one, we would argue. We have really good levels of nursing and medicine and other inputs, psychiatry, pain management, that are only available on our inpatient unit. And we have quite a high length of stay compared to other hospices, about 13 days rather than about 11. And we argue that that is because we're using it for the people that have the most complex of needs and are unstable in their condition. The other reason why I think outcomes can be important on this is that we are sometimes seen as fussy in terms of who will admit, particularly from hospital. And that is because we are increasingly protecting our beds for those people that we think most need that intense resource I described earlier. So here's that data again for the last 2 years. And you can see that the majority of people that are admitted to our inpatient unit are either unstable or deteriorating. If I'd shown you data pre-pandemic, it was even better at demonstrating that we were using our inpatient unit primarily for people who were unstable. But in the pandemic, we opened our doors wider to take people who were deteriorating or dying in hospital to help our colleagues in that context. And it's very, very hard to change that trend immediately. But it isn't just that we take people who are unstable. We have an internal ambition, which is to move them from unstable to another phase within 2 or 3 days of admission. And you can see that we largely achieve that. That's different to the community, as I've described earlier. And this is a good example of trying to help our commissioners appreciate that what they buy from the inpatient unit is different from our community services. And we actually need both to meet the needs of our broad population. We can challenge historical beliefs about where resources should be directed in the future if we show good outcome data. And as I say, at the moment, the majority of our funding from our commissioning groups is for our inpatient unit, despite it being the tiniest bit of what we do. And so we do need our local commissioning groups to think about investing further in not just community services, but our support for care homes, for example. And so being able to show differences in outcomes across the different areas can be really helpful. I've got a few emerging insights here that help us with those kind of conversations. So you can see at the top of this slide that actually the number of admissions has gone down significantly in the last few years, and that began in the pandemic, and it hasn't picked up since. We have more people dying at home than we have historically, more people dying in care homes. And as I said earlier, we have good data that shows that residents in care homes have increasingly complex needs. The type of patient we look after has changed hugely in the last few years. We now have more people with a condition other than cancer going through our hospice services. 54% in the last quarter had a condition other than cancer, and the age profile of our patients is much, much older. You can see data here that's of value when we talk to commissioners, for example, about the complex and multiple nature of the challenges that people have when they're referred to us. So people have very serious symptom burden, but they also have a broad range of symptoms that they present with. The final suggestion about why you might want to use outcomes is that it can help commissioners and the hospice think differently about how we might operate in the future. And that's important. What we were doing 20 years ago is certainly not right for what we're doing today. What we were doing 5 years ago probably isn't that appropriate. And so we need to look forward and think anew. But how fantastic to have measurements around effectiveness and impact to make sure that we don't throw the baby out with the bathwater. I don't have time to talk about the detail of this project, but I thought I would just describe a recent project funded locally where we were asked to think creatively about how to keep much older, frail patients out of hospital during the winter months in the UK. And this is always a problem for us, but it was exacerbated last year because we had the new Omicron variant just before Christmas, which people were very frightened would result in a lot of hospital admissions. And so we made an offer to the system. We agreed our approach and the outcomes in advance of starting, and we reviewed that data that came through that project, both in the course of it and its end. And we were looking, in essence, to give the right care at the right time, in the right place, from the right professionals to people that were either dying at home or in care homes, and how we avoided unnecessary hospital admission. And what I wanted to show you very briefly was just how much focus we gave to data that is tied up with outcomes and effectiveness, both in describing the population that we served and also the outcomes, which indeed were very positive. And if you're interested to know more, I'm going to leave my email address at the end, but please come back to me and I'd be delighted to tell you more about this. So just to finish, I think that if we, any of us involved in planning, delivering, shaping end-of-life care, could have a greater focus in our thinking on outcomes, on effectiveness, rather than simply experience and safety, we start to shape policy either at ICS or at regional, national level, that really is focused on what's important to patients and allows a kind of cost-effective and cost-efficient care. We do need to agree the outcomes that we will all measure, and the more that we can measure them in the same way, the stronger our shared data and the greater the opportunity to benchmark performance between us and across us. I really want to share our data. I was delighted to be invited to speak today, and I'd love to see the data of other providers. It's a great benchmark for us at St. Christopher's. It helps us know where we can and should improve. And it helps us in our confidence as we talk to policymakers to know that actually the story we're telling is not simply about St. Christopher's. It is about the broader hospice sector or the broader palliative and end-of-life care sector. And I think the other thing is that we have some great outcomes, but we need to continue to develop them for new groups of users. There's been work done on outcome measurements for people with dementia. We need to think about the relationship between outcome measures that are specific to palliative care, with those that are related to frailty, and so on. And certainly a provider like St. Christopher's can't do that. We need the academic head of and thinking of organisations like York Hull. We need to think internationally and look at the work that's been done in Australia and other places. And I think together we could make a real difference. That's my email address. I'd be delighted to hear from anybody who'd like to ask more. And thank you so much for the opportunity to join you this morning.